All right, here we go. Welcome to the Nursing Home Warrior Podcast. I'm Paulie Moran.
Hi, welcome. I'm Danielle Lieblein.
This is my nephew, Nick Kerimian. We're doing Nick Kerimian 2.0 today.
Hello.
So you want to tell everybody what Nursing Home Warrior actually is?
So Nursing Home Warrior was started and created because residents in nursing homes need an advocate. They need a voice. And many residents do not know what is appropriate and what is not appropriate. Did I just say that right? What is inappropriate and what is appropriate? And families don't know either. So we are here to teach and educate what actually is supposed to happen in a nursing home, and when something doesn't happen correctly, what are the steps to take to rectify that mistake?
Yeah.
During that time, we've also started something called Project Silver Threads,
Where we collect clothes, people donate us clothes, we buy clothes, and give them out to nursing homes in need of clothes. You have no idea that people in nursing homes really have nothing. We spoke about it in the first show, I think, that on the Medicaid they get, or Medicare, I always get them confused, they only end up with like $50 a month to buy clothes. So
well, not even just clothes, right? So
to buy
they get
anything.
$50 a month to get their hair cut, to go to the vending machine, to buy anything.
Right.
That's $50 a month, and that goes pretty quickly. So Silver Threads makes these cozy boxes, and we send them out to nursing homes.
this is a cozy box,
And they're
nice big box.
filled with either gently used clothing or brand new clothing. We just got a whole bunch of brand new clothing from Sonia and Laura, and then we also went to Target and bought a bunch of clothing. And we fill that box up and we ship them out to nursing homes so that residents who maybe don't have family or haven't had anything new in a really long time can get a new piece of clothing.
And each box holds between, we counted one time, between maybe 40 and 60 pieces of clothing, depending if it's a big sweater or, small pants or anything like that. We've been getting a ton of donations. Tara Carlin, Dolores keeps sending us stuff.
Dolores, amazing. Tara, thank you.
Suzanne Rickus and her sister Anne-Marie sent us stuff twice. Debbie McKeon Higgins brought us stuff. We got a giant check from one of the ladies at the Harmony Bar who doesn't want us to mention her name.
But thank you so much for that.
Yeah, she gave us a big old check, lots of zeros.
Yeah,
So that was very
great.
good.
Yeah. And with that, we were able to ship out 10 cozy boxes to Brooklyn the weekend before last because I was too lazy to actually drive to Brooklyn and spend the day there. So we went to FedEx and just dropped them off. But we've gotten really good response from them, and people are thanking us and sending us letters saying that they appreciate everything we've done. So please keep the donations going because we really are trying to make a difference for the residents who live in nursing homes.
Yeah, and the end of next month, September 30th, we're doing a pop-up shop in the Bronx. I don't remember the name of the place.
Goldcrest.
Goldcrest. So what that is, we're going to go in and set up clothes racks, all brand new clothes, and let the residents come down and actually shop. Should be good.
It's going to be a lot of fun.
Yes.
Yeah. So Nick is here to teach us the difference between assisted living and nursing home because you've worked in both types of facilities.
I have worked in both types of settings. I would say the main difference is acuity level. In nursing homes you have skilled nurses, whether it's wound care, Foley care, if you have a skilled need in regards to therapy, physical therapy, occupational therapy.
So I'm sorry, just to stop you. Let's tell them what skilled need is, right? So
Also,
respiratory.
too, he's a nurse, so he's doesn't clean the place. He's a nurse.
I think the scrubs gave it away.
Anybody could best buy scrubs.
So let's just tell them what a skilled need is, right? So respiratory therapy.
Yeah, respiratory therapy, physical therapy, speech therapy, occupational therapy are all considered a skilled need. So in the skilled nursing setting, all of these disciplines, so to speak, are staff in a
Dietitian, speech therapy.
So in an assisted living setting, all of these disciplines are typically brought in from an outside or third-party agency. So really, in assisted living, that building, that operation really provides, your basic needs, whether it's hospitality, housekeeping, nursing and care, and then any skilled need would need to be brought in from a third-party company.
So there's a couple of differences that stick out in my head right away. Number one is most assisted livings are private pay.
Yes, they are.
And that could run from anywhere from $9,000 to $20,000 a month, depending on what facility you go to.
Yes, there's all different criteria. It's mostly like what style room you want. So you could be in a studio, you could be in what we call a suite. It's like a tandem, almost like dorm style setup with a common space that you share, or you could be in a one-bedroom.
And then in nursing homes, it's usually, for the most part, Medicare, and then it switches over to Medicaid for long-term residents.
Yeah.
And very few people actually pay for long-term care in a nursing home because it can go up to $15,000 as well. And at that point, some family members just keep their loved ones at home with private aides.
Yeah.
So that to me is what stands out the most, is that you go to assisted living, it's kind of more like they have a restaurant in there. You're definitely more independent. You have to be able to do a lot more things on your own. You don't need somebody to give you your medications, let's say, all the time. You don't need somebody to help you get dressed, although you can. But if you do need those things, you definitely have to be in a nursing home, right?
With the two, who makes the deciding factor of whether you can be in a assisted living or in a nursing home? You know, we talked about the PRI and I remember, in the nursing homes. So if the family says, no, my mother doesn't need, she can be fine on her own, but maybe she really can't.
So, I mean, there's a couple of variables that come into play with that. One is like your financials. Can you afford to be in a private pay setting? Or do you have Medicare and Medicaid set up to stay in a long-term facility? The next criteria would be, are you an appropriate, resident for the assisted living setting? Like I said, they don't have all the skilled disciplines on staff. And comparatively speaking, like if you're in a skilled nursing setting, you can receive physical therapy, occupational therapy 5-6 days a week. And in assisted living, it's considered a home-like environment, so it's only covered 2 to 3 days a week for those skilled needs. So those are some of the main differences. And ultimately, a physician needs to sign off for you to be able to be in either setting.
Higher functioning people go to assisted living as opposed to going to long-term care nursing home living.
And can you just come and go? Like, can you just walk out the door, be like, Nick, I'm going to the gym. I'll be back in an hour.
You really can. We ask that you just like sign out. At
Let people know you're leaving.
Assisted living.
In assisted living.
Yes.
In skilled nursing, there was like the front door was like this force field that if anyone passed, it was considered an elopement if they weren't. Had a physician's order that said like out on pass, I think was the actual order that
Your family member was taking them out, they would go into a doctor appointment.
So.
Right. And they don't usually, long-term patients usually just go out for mostly doctor's appointments, I'm going to say. Very few family members take them out for lunch.
It's funny you say it, because I kept meaning to bring that up. Like, it's okay for a family member to go to a nursing home and take their family out, right? Like special occasions. Obviously, you have to let people know you don't just, we're leaving, and have the proper ways to get them in and out.
So part of the problem, and you can correct me if I'm wrong because you're the nurse, I'm just a dietitian, is that when you have somebody who's in long-term care and they're going out for 8 hours, right? A lot of them are incontinent, so they're wearing adult briefs and they're in a wheelchair. So who's changing them in those 8 hours? I mean, that's always a problem, that they're sitting there in their stuff, or who's transferring them to the toilet? Like,
are you specifically speaking about like when family takes them out?
Yeah.
Oh, okay. I mean, if they can transfer on and off a toilet, like then you can be able to. But if they're like a Hoyer lift, then they're probably not being changed.
Yeah, so they're coming back a little messy.
Well, they're coming. Well, or uncomfortable. I feel like it's not that easy to take somebody out. I mean, for me, an hour or 2 hours is fine. 3 hours is fine. But after that, it starts to get. I feel like it gets a little
But wouldn't
Ugly.
wouldn't like anybody, the nurse or somebody, be like, listen, this person should only be out for 2 or 3 hours.
we'll tell them
And
that.
this is the work you're going to need to do if you keep them out for 8 hours.
Yes, and they have to go to therapy to do like car transfers and make sure that the family member is able to handle that 100%. But they're usually short-term, quick trips in long-term care when they take them out of the building. They're not spending hours and hours out because it's very difficult to take care of some of them.
So, one other main difference between skilled nursing and assisted living is the activity staff. In a skilled nursing setting, you do have your activity staff, and they will, do certain trips, and they'll take you out to the patio and do bingo and stuff like that. And in the assisted living setting, like today, our residents were at Cedar Beach.
Nice.
Sitting on the beach having cocktails. They brought like a blender and they were doing so.
That's not happening in this.
Part of it
It's
is
like the
so,
villages down in Florida.
like we staff a nurse's assistant, and a lot of the residents that go on this trip need to be able to like transfer onto a toilet in a public setting.
place,
so.
yeah.
Right. Yeah.
But that's great. They must love that.
Yeah, so they get to sit on the beach and they're still receiving their care. We'll pack their meds for the day, so they'll get they left at like 9 a.m., so they'll have their morning meds and their lunch meds. So that was really nice.
But with the medicine, like you just have it. Like, are you completely responsible? Because we talk about medicine all the time. That in the nursing home, like you get your meds between 9 and 10, 2 and 4, whatever it is. Like, are you guys really responsible for that in the assisted living, or is it still kind of up to the person?
It really depends on how high functioning the residents are. There's like a self-med administration assessment that I do when people come into the community, and they really need to tell me like the exact medications they're on, why they're on, some side effects with the medications, and if they can relay that, like, I take these 5 medications, this is why, then they can self-medicate. If not, we reserve that right, and we put them on medication management so that they don't harm themselves.
I'm going to say 99% of residents in nursing homes do not self-medicate. Right?
I agree with that, yeah.
I'm going to say, maybe an inhaler at the bedside, possibly, but I feel like there's not many residents in nursing homes who are able to self-medicate.
In assisted living, I would say in my building, we have about 15% of the building.
Which isn't a lot either, actually.
Like 20 residents.
Mm-hmm.
I guess it's better safe than sorry. Like, you guys are making sure they're getting what they need when they need it. And
Well, the other thing is, I don't know, if they were getting a narcotic, right? You're not going to give them a whole thing of narcotics without making sure that they know.
Yeah.
We have a few residents in the community that do self-administer narcotics. The criteria is that it has to be behind 2 locks. So your locked door would be your first lock, and then there's a lock cabinet in the room. So.
And they're the only ones with the key.
And they're the only ones with the key.
Well, obviously,
as
you
well,
guys as
yeah.
well. You
We
have
need
to put it
get
in
into
there.
it, yeah.
Right. Narcotics seems to be a hot topic in the nursing homes because when the resident first comes into a nursing home, their medication doesn't come with them from the hospital. So what the nursing home has to do is call the pharmacy after we get the orders, and then it gets delivered. And a lot of nursing homes on Long Island, the pharmacy's in New Jersey. So we have to wait for it. So the narcotics are big because people come in for hip surgeries, knee replacements, and they want their narcotics.
Oh, they're in pain.
They're in pain, but we don't have it. So we have to go to something called a Pyxis, or I think that's what it's called, like that.
Yep, fixes, yeah.
And they have to get the narcotics from there. But for us, I feel like at least at the beginning, it's better for us not to give a resident the narcotics and be like, here, take them every 4 hours. I think it's better for us too.
Yeah, definitely.
To see when they're supposed to take it.
Definitely. That's a similarity between assisted living and skilled nursing is like when you're coming from a hospital setting, they have a pharmacy on site. They have a Pyxis, which is a gigantic medication administration
Vending machine almost.
machine where it's usually fingerprint and you put in the resident's name and the narcotic that you need, and it just kind of pops out like a dispenser. So even in skilled nursing, they had one machine, I think, for the building. In the hospital setting, each floor had one. And then we just rely on a delivery pharmacy. So that is like a big challenge upon admission in the assisted living setting, is like making sure the discharging rehab or skilled nursing facility sends all the scripts to the resident's designated pharmacy.
Because it's the same thing. Nobody's coming in with a bag of their pills that they left the rehab place from, right? Like you don't, if you discharged, they were there not long care, but they were in your place for a rehab. They were there for 6 weeks. You take all their medication and send them with nothing, right?
No, we can give medication on discharge.
They could take it with them?
We do. We've given medication at discharge. Yeah.
Sometimes.
Okay.
Yeah. Yeah, and then hopefully, but not an extended amount, like a little bit for them
To
to
get
to
you
the
through a couple of
pharmacy.
days.
Yeah. Some of the other differences for, I think, for assisted living and nursing homes are that nursing homes have speech therapists on staff all the time and dietitians. So when there's a problem with chewing or swallowing, we're able to pick that up pretty quickly. We're able to see a weight loss because weight loss leads to many other things, right? Malnutrition, pressure injuries, infection. So if you have a patient, a family member that you're trying to decide between assisted living and nursing home care, it really has to do with, I would think, I know they have dementia care units and memory care units, but I feel like it really has to do with how much they can also advocate for themselves while they're in there, right? Because
I agree.
it's really important to advocate for yourself while you're there in the assisted living, because you don't have those other supports watching them, right? So they're not having a dietitian watch them eat at their meals, or watching their weight, or checking their labs, and the speech therapist seeing if they're pocketing food, are they choking. So you have to be able to say, you know what, I'm having a problem swallowing, to you, where you say, all right, now I'll go get somebody to come in. So I feel like you have to be able to advocate for yourself a little bit more when you're in assisted living than you might have to do in a nursing home.
I agree, and there's definitely requires a certain level of family involvement in the assisted living setting. But I totally agree with in regards to like a speech and swallow valve. If somebody's having difficulty chewing or swallowing, or risk for aspiration, like we would have to send a home care referral through a home care agency. It could take a day, 2 days, 3 days to have an actual speech pathologist come in and do a swallow valve on somebody who could be potentially choking. Obviously, there's interventions that nursing can put in place before then downgrading their diet, or getting a chest X-ray and doing an assessment. But
Right.
definitely things are a lot more spread out in the assisted living setting.
Have you noticed more family involvement in assisted living than when you were in a nursing home, or
The families are in my community are wonderful. Like, they are very involved. They're very helpful. Just even in regards to like follow-up appointments, like if a resident goes to the hospital, they get discharged and say they have a heart attack or a stroke, like they need to follow up with cardiology, neurology, pulmonology. So in our setting, most buildings don't even have a bus or any way to transport residents to follow-up appointments after like a major medical event. So the families are required. So we help a lot, but the families are supposed to like make appointments, take their loved one to the appointment. Our building has a bus, and we do medical transport twice a week. So.
Unfortunately, in nursing homes, that's why you became the nursing home warriors, that their families aren't that involved, and they need this. They need her help.
So we're going to talk about that in a second. I think we're going to cut to a break, if that's okay with everybody.
Yeah, sure.
Yeah.
Empire Automotive Group is about people, their families, and their dreams. We strive to create meaningful connections. To be bold. To embrace evolution. Wherever the road might lead us. And to build trust with our employees, customers, and their families. Empire Automotive Group. Accelerating the lives of future generations of drivers.
Protect your family. Buy LifeVac now.
Thank you, Dad.
That was us over 10 years ago.
Now LifeVac is responsible for saving over 4,000 lives from choking.
In the time it takes you to pick up the phone and call, another life could be saved.
The LifeVac saved my life in 1 to 2 seconds.
Protecting families has always been our mission. I'm sure you love your family like I love my daughter. Do us all a favor and get your own life back now.
Go to lifevac.net or call 877-LifeVac. Order now.
And we're back. Thank you, Arthur, so much. Arthur Lee is such a good guy. He sponsors us all the time. He loves Nursing Home Warrior. LifeVac is the best. Everyone should have one.
And thank you, Michael Brown. Because of you, I was able to get a new car very easily. So anyone who's looking for a car, please look at Empire Automotive Group, because Michael Brown really is, honestly, he's the best. He's the best. So thank you. So now we're back with Nick, and I actually have a question for you.
Sure.
I don't know if you're prepared for it, but you did work in a long-term care setting. What was your biggest challenge as a nurse?
I think there were quite a few challenges with the long-term setting. Like, you're very restricted by Medicaid. You know, the skilled nursing setting is almost like a miniature hospital setting. Like, you can administer IV antibiotics and IV medication. So it's really just bringing it all together in that setting, as far as like communicating with the doctor who's maybe only on site once a week, you know, getting certain orders, and I'm having a little trouble explaining this.
So what I see is that, so a nursing home or short-term rehab, it's all in the same building. And the short-term skilled nursing care, the doctors see the residents a lot more, maybe 3 times a week they go back to see them, where the long-term floors, where the residents are generally more stable, let's be honest.
Yeah,
they don't need to be seen every day. Definitely. They are stable. They have monthly reviews. They have to be seen monthly by the doctor. So the doctor does see them monthly. But what I find is a challenge is that people come in thinking that we are a mini hospital, and we're really not, because if I want to order labs for someone, right? I have to then, you know, you get the doctor's order, and then you put it in the lab book, and then the lab person will come. If it's a Sunday, she'll come on Monday, but whatever. And then they put the labs in, and you don't get that lab result back until way later in the day, if not the next day. Mm-hmm. Where in a hospital, all that happens right away.
Yeah.
You know, it's right there for you. It's a little bit slower in nursing homes. Like, I had a woman say to me the other day, my mom's stomach is bothering her. Can I see a GI doctor? I said, well, let's let the primary care physician take a look at your mom first and see if there's something that he can do. And she's like, no, I want a gastroenterologist. Where is his office? I said, I'm sure it's somewhere
not in this building
on Sunrise Highway. I'm not sure where her office is or his office is. And they're like, they're not in the building. I'm like, no, like, there's no doctor sitting here waiting to see, especially a gastroenterologist, waiting to see your loved one. Like, yeah. This is not their primary job. They come in, and if it's an emergency, we will send them out to the hospital. It's not like we're going to keep them here and hold them hostage, but they're not just sitting here waiting. So yeah. I find that that's definitely a challenge that families don't understand, that there's things that we just can't do, right? We can't do, stat labs are not stat labs in a hospital. A stat x-ray is still going to take a little while, yeah, right? It's not happening as quickly as it is. And I don't think families quite understand that. You know,
the other thing too that I don't think they realize, it's a business, and it's run like a business. Unfortunately, it shouldn't be run the same as CVS or, you know, a gas station, but it's a business, and everybody's worried about money and Medicaid's insurance, and they don't want to pay for anything. So you have to go through every step.
Well, the doctors, as long as the doctor orders something, it's going to happen. It just might not happen at that second, right? So if the doctor says this person needs an x-ray of their hip because they fell, let's say, it's going to happen. It's just in the hospital, it would have happened a little bit quicker.
Definitely.
Yeah, definitely. So that's a problem. And blood work is never a problem. I feel like whenever someone needs blood work, that always happens. But
could they do x-rays in a nursing home?
Yeah, we do portable x-rays. We do chest x-rays all the time, I feel like.
I always make this comparison with some of the families in my community. Like, I was in a motorcycle accident. I was a code trauma, which is they cut your clothes off, you get a brain CAT scan, you get all these different neuro exams, blood work, this and that. And that happened in about 15 minutes after I got to the hospital. So in a skilled nursing setting, or even in an assisted living setting, that would probably take 3 months to get all of
Literally.
that workup done. If it was labs or a CAT
Literally.
scan or see a neurologist and see a trauma doctor, see the orthopedist, like, you're seeing all these different specialties and getting all this different intervention. And when I tell you that happened in like 15 minutes, I was barely conscious for it, but
you were in a motorcycle accident. You were going
spreads out.
X amount of miles an hour and then going 0. So,
Yeah. But I'm just saying, all those moving parts in an acute care setting, like a hospital, is very different for that reason. Like it doesn't happen that quickly.
So quickly. My other question for you is, because you have worked in both settings, is have you noticed if there's more people with DNRs, do they in the hospital, in the assisted living, or in the skilled nursing care facility? And the DNR is a do not resuscitate. So if your heart was to stop, do you want CPR to happen for you? And I just want to say one thing, because, and I think you can definitely agree with this, is that when deciding whether or not you want your family member or yourself to be a DNR, do not resuscitate, please understand that it's not going to happen like it happens on Grey's Anatomy, right? You're not going to have a code and then 10 minutes later be in your, sitting in your bed eating. I mean, we could talk about what a code looks like in a nursing home, and it's far from TV-like.
I agree.
It's horrible.
I don't think any of us outside of it want to know what a code is.
Okay.
We would like to think it's what happens on Grey's Anatomy,
It's not,
and that's
though,
all fine.
But my question is, do you find more people in the nursing home have a DNR, or people who are more acutely aware in the assisted living are saying, you know what, I don't want to go through a code like that?
I mean, I've really been pushing advanced directives on all the residents and families, just to kind of communicate those needs, because if you don't know like what a code is, it's when your heart stops beating and you have no, you have no
Explain to them.
pulse, you're not breathing. So, if you don't make that decision in advance, and you on a day-to-day basis, you may be telling the nursing staff or the doctor, like,
yeah, but unless it's in writing.
but if you don't fill out this paperwork, you can't limit the interventions that you're going to get. So I advocate for the MOLST form. It's medical orders for life-sustaining
for all
treatment.
your wishes, not just
For
DNR
anyone
and,
who kind of comes
any
into
medical,
the building.
Yeah.
Well, that would be more of like, yes, but really the one that we're really worried about is the DNR, because tell them what happens.
Yeah.
So if you don't have a piece of paper that says "do not resuscitate," you will be resuscitated in the event that you stop breathing or have no pulse. And that's not always
It's not pretty,
what you want
actually.
for your loved one. Especially like during COVID, I started wearing running shoes in the hospital because we were coding people 2-3 times a night. And you're breaking ribs, and it's very
Right, it's
traumatic.
violent.
And
But a code in a nursing home is not like a code in the hospital. Let's be honest, right? We
It's
can't
not.
administer medicine. We're not putting an IV in you and giving them epi. We're waiting for the paramedics to come to do all that, right? So the code in the nursing home happens. We bring the crash cart. We bring the AED. We open up, we do what we got to do. We're pounding on their chest, and we're still literally waiting for the paramedics to come to do the rest of it.
exactly, yeah.
So it's not like in the hospital where they can get them back so quickly. It's not going to happen like that.
Yeah, you're definitely not like pushing epi like you would in
No.
a code in the hospital. And the nursing home I was in, we actually had a PA and an NP on staff, so that physician assistant, nurse practitioner. So when there was a code, they would come and they would be able to give you certain orders, like
Great.
start an IV, and we'd start a line and start hanging fluids before EAS arrived or EMS arrived. So.
Very interesting.
Yeah, so it's important to have that conversation actually now before you get to that point. Like, when the resident is already in the nursing home and they're maybe having some sort of memory loss or cognitive deficit, you want to have it now and say to your family member, what do you want? Like, what is it that you want? You're going to be 95 years old. What do you want? Do you want to be resuscitated? Because we need to have that conversation. It's something that should happen today, actually, not at that time. But I was just curious if there's more DNRs in the assisted living where they're more acutely aware, or in the nursing home, I feel like a lot of the families make that decision as opposed to the resident.
Yeah, I agree.
So I was just wondering if there was a difference.
I've been seeing a higher influx of them in the last 6 months, but it's it comes with like education. A lot of people don't prepare for that portion of their life. So it comes with a lot of conversation with the resident and the family, depending on who can make decisions.
But you
or
said all your
involving
residents were on the beach today. They're not thinking about, that last day, that last chance. And listen, it could happen to all of us tomorrow, but
Yeah.
they're not thinking about it. In a nursing home, I would think it would be like in the packet that, when they come in, be like, listen, here's 10 pages. You really need to think about these.
Right, but again, I feel like in the nursing home, it's the family that's really drives that decision more than the resident.
The residents kind of past the point of making that decision sometimes,
They might
right?
be, yeah. So I feel like that could be a problem. But it was amazing having you on our show today.
Yeah.
Yeah,
Thank
Nikki
you.
Kerimian 2.0.
Appreciate it.
Thank
you.
you.
Guys.
We had technical difficulties last time. Danielle's mouth was moving, but there were no words coming out.
That would never happen.
She's fixed this time, though, as you can tell.
Yeah, thanks for having
Thank
me.
you, everybody, for watching. Please donate, donate, donate. We need as much as we can get.
Take care.
Da 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 da.